anything you'd like to say?
I do not, thank you, though. Other than to echo your welcome.
Okay, so I don't have any announcements. Because we do have some time constraints, I think we should, for some of the members, we should get started. If that's okay with everyone, with our presentations, our subgroup presentations. So we will begin with our pediatric subgroup. If you'd like to introduce your members and get started, we'd appreciate it.
Sure. My name's Hakan Koyman. I'm a pediatric dentist, and I'm also the dental director for Maryland Healthy Smiles in the state of Maryland. With me is Jonathan Dayton.
Good afternoon, everyone. Executive Director of the Maryland Rural Health Association, excited to present some findings.
And I also have as an invited guest for our speak today, President-elect of the MSDA, Dr. Winifred Booker, who's also on the call during our presentation. Thank you, Dr. Booker.
Thank you.
So I guess we'll begin with a presentation. Do you have that up for us? Thank you. So, when tasked with doing sort of this update, the first part of sort of our discussion in the beginning of the task force was talk about researching what the barriers to care were. And on this go around, it was a little bit, readdressing those barriers and then coming up with solutions that maybe we can do to help overcome some of those barriers to care that children are having in the state of Maryland. Slide, please. Just to review, currently there's over 400,000 children on the Maryland Healthy Smiles program. To remind everybody, back in 2010, the Dental Home Project was started in the state of Maryland, where every child that has Maryland Healthy Smiles is assigned to a dentist when they come on board with Maryland Healthy Smiles. Again, just to reiterate on that program so people understand, that does not mean that's the only dentist they have to go to. They can go to any dentist that they want, but that way they all have a dental home and know where to go in case they're having a problem or where to at least get introduced into dentistry. As far as the last statistics go, Maryland has 72% utilization by its members, meaning that 72% of children had a visit within the last year, which is pretty high utilization and is really good. Slide, please. But we want to think about the other 28%. I mean, how are we missing these kids? How can we make it easier, more feasible for them to get into care and to get into care earlier? Slide, please. So the first, and these are not in any particular order, but they kind of build on one another. The first one is transportation. One of the problems is that children are reliant on their special population. They're reliant on their parents to drive them to dental visits. And, for parents, sometimes transportation is not reliable. Gas prices, tolls are added barriers to care. And as we've seen this year, has become even more of a cost pressure on families. Just some of these families have only one car. Some of these families in metro areas are living on bus lines, that maybe they missed the bus or they're late to their appointments. And then when you think about rural areas, some of these children and families are having to drive long distances in order to see dentists, especially when it comes to specialty care. Slide, please. Socioeconomic status is another barrier. I mean, the lower you go down in socioeconomic status, the more times families are, working several jobs to make ends meet. Either single parent families, even if they're joint parent families, both parents are working. A lot of times, grandparents or great grandparents are the ones that are taking care of these kids most of the days. And in order to do treatment on these kids and have a guardian there that is able to sign off on paperwork and things like that, causes parents to have to take time off of work, can cause daycare or babysitting issues for other children that they may have. So, these are very difficult obstacles for a lot of these parents and families to go through. Slide, please. Again, geographic, we talked about earlier, and transportation and geography kind of go together. Parents need to travel long distances. Again, the cost of gas and tolls because they're having to drive those long distances. And issues with transportation services. With getting some of the transportation through the state organized is not easy to do. It's difficult. There's a lot of barriers to that. Sometimes, they will come. I've had families that report that they try and set it up and then nobody shows up. So it limits them a little bit in scheduling appointments, and it also limits parents a little bit, when they're scheduling an appointment to see a provider, if they end up being 20 minutes late because their bus was late or transportation didn't arrive, it allows them to not be seen because most providers are going to already have said that they missed their appointment. So this is a big problem. Slide, please. Education, I think, is one of the key components though to barriers of care. I think there's a lack of education on the importance of the age 1 visit. Most parents still believe that the first dental visit should be at age 3. And in fact, in a 2018 survey by the Academy of Pediatric Dentistry, it revealed that 74% of US parents do not take their child to the dentist by their first birthday, and that's across all socioeconomic strata. And dentistry, it just seems like we're not aligned with medicine. They're in medicine, it's very much about those wellness visits in the beginning and making sure kids are seen early and often, because we want to work on prevention with these kids and catch things early if there are issues. And I feel like the messaging to parents is not the same as far as that age 1 visit goes. Slide, please. And parents and practitioners that are outside of the dental field, and even some that are in the dental field, there's a lack of education on baby teeth a little bit. Parents and grandparents, will kind of say like, well, teeth problems just run in my family. It doesn't matter if we go see the dentist or not. Or, they look inside the mouth and say, well, I don't see any problems with their teeth. Or the other thing is just the importance of it. People just say, well, they're baby teeth. They're going to fall out anyways. Why do we need to save them or fix them? And they're just going to fall out. And in fact, 28% of preschoolers do have visible decay well before entering school. So it's again, one of these things that people usually don't do something with kids, and especially when there are barriers to care, until it gets to the point that something is bothering their child or their child is waking up or complaining of pain. Then there becomes an issue as far as why they need to go see the dentist. And physicians and PAs are really not taught about teeth. I was going to humor you guys with a video, but I didn't want to take 10 minutes of time. But, there's a video that shows about how in medical school they're teaching about bones, but they don't teach about teeth at all, and it's, and if they do teach them about teeth, it's like there's upper teeth and there's lower teeth, and that's about it. There's a real disconnect between the medical field when it comes to dentistry and sort of coordinating treatment together and talking about these cases and how teeth relate to overall oral health. Slide, please. Another big barrier to care that we've talked about, among many of the other talks, is the lack of workforce. There's a lack of specialty providers in rural areas. There's a lack of auxiliary staff to treat patients, dental hygienists, dental assistants. Everybody's finding difficulty in finding staff and finding dentists. If you pull most of the dentists, even in this group, they would say, I'd be able to see lots more kids or even adults in this matter if I had more assistants to help me or more staff, but I just don't have the staff to do it. So this lack of workforce is an issue that we kind of need to come up with solutions for. Slide, please. Operating room access is another huge barrier for these kids to get treatment. And it's a barrier for practitioners also. There's limited access by providers to treat children under GA. And patients are waiting up to 1 year in order to be seen under general anesthesia. You know, whether it's the dental school, whether it's private practice, whether it's out on the Eastern Shore Chop Tank, you know, I mean, these wait rates and the difficulty of getting in is getting more and more difficult. And across the state, more and more ORs are starting to close their doors to dentistry because it's just not something that is financially viable for them to keep in their buildings. And this, you know, all this operating room access, the problem with it is it increases the likelihood that young children and children with special needs will have increased dental pain and abscesses as time goes forward. Slide, please. Relevant research. I mean, there was, you know, a study that I just wanted to show, and it was an interesting study. It was out of the Journal of Dental Hygiene back in '97. But they did a focus group with actually dental hygienists and dentists in Maryland, talking about, you know, how can we prevent early childhood caries? They wanted to find out from clinicians what those perceived barriers to care were. Slide. And, you know, kind of the same three key themes had emerged. You know, the patient challenges of limited resources, low oral health literacy, you know, the young age of many parents, lack of transportation, and language and cultural barriers. Slide, please. You know, education, again, as far as low oral health education amongst parents and physicians, and also poor diet education. You know, a lot of parents think that they're doing the right thing. You know, they think that, well, I'm just giving my child diluted juice, so they're not getting as much sugar, or, you know, we're only do things that are organic, or we'll give smoothies to my child and I make them at home. But they don't understand, you know, diet education at all. Slide, please. And the other barrier to care, you know, that clinicians felt was that there was a lack of interprofessional collaboration. There was this desire to work more closely with pediatricians and hospitals to educate about oral hygiene and importance of primary teeth. You know, a lot of the responses in that article was, you know, could we be in there, you know, from day one when the patient is born and start putting that message home about dental care and how to brush your infant's teeth, and, you know, what to do and what to be looking for when we give them the plethora of information when they have their newborn. And more collaboration with school nurses, which can be a gateway for children that have untreated dental problems. Slide, please. I'm going to hand it over to Jonathan Dayton, who did some research for this talk today. Jonathan?
Yeah, absolutely. Thank you, Dr. Koyman. So at MRHA, you know, one of the things that I'm not a huge expert in is oral health care, background in a lot of different things. And so I'm a big proponent, though, of data. And so what we did at MRHA is we put together a brief survey that we sent out to our membership. We also solicited some feedback from social media, and we also sent it out to, here in Western Maryland, the Allegheny County Health Planning Council or Coalition, to get some feedback. We had about 39 respondents over about a 2-week period. And currently that survey is still open for respondents, and I'd be happy to share more data as we collect it. Slide, please. So we did, the first question was ranking some barriers to oral health care in rural communities specifically. As you can see highlighted in purple are the top 4 low provider population ratios. Of course, that's a huge issue that we've talked about earlier in the presentation. Inadequate number of dentists who accept certain insurances. They wanted insurances that had discounted fee programs or schedules for care, insufficient or lack of insurance benefits. So everything there at the very top is related to just coverage in general. Transportation is a huge barrier, especially for rural communities. And the last 4 there are just general things, childcare being an issue specifically. Also just awareness about the importance of oral health care for pediatrics, geographical barriers, and cultural barriers and stigma as well. Slide, please. We did a breakdown too of the respondents to the survey. Again, it was sent out primarily to people that worked in healthcare, but we also solicited from just general public as well. Healthcare providers made up 23% of the survey respondents. 33% were non-clinical, but a healthcare worker. 33 were other, and 10% were parents. This data is good to note as we continue to present some data. Slide, please. Geographically, the survey respondents primarily were from Western Maryland. Of course, we did send it out to the Allegheny County Health Planning Council or Coalition, but we did have a plethora of survey respondents from Garrett County, Allegheny County, some from Southern Maryland and Eastern Shore as well. Slide, please. And then, of course, just some general questions we did ask were levels of education. The majority did have a master's degree or higher. Of course, bachelor's came in at 23%, associates at about 13%, and high school education only at 15%. Slide, please. And here's the kicker question to start the survey out after we got through some general questions. And it was, is your community doing enough to address oral health care challenges? And the answer is overwhelmingly no. And again, one of the reasons why the task force is established is to address some of these challenges. But it is good to see some data to support the need for the task force recommendations and the work that we're all continuing to do. Only 15% of the respondents indicated that their community was doing enough to address healthcare challenges. Slide, please. And specifically related to pediatrics, do children in your community access dental services on a routine basis? And overwhelmingly, over 50% of the respondents said that children do not access dental services on a routine basis, which again is very alarming, especially knowing the importance of having routine dental care, not only for adults, but for kids as well. Only 12% said yes, that children do receive services on a routine basis, and 33% were unsure if children do. Slide, please. This was a good question that Dr. Koyman wanted me to put into the survey. And, you know, earlier we talked about the importance of that one-year-old visit. And we asked, what age do you think a child should see a dentist? And the majority of respondents did indicate 1 to 2 years. We did have some that indicated even sooner, but, you know, we do have some individuals that responded at 3 to 4 years and 5 to 6 years. And we know the importance of having those early dental visits. And even though the majority did respond with 1 to 2 years as the indicator of when they need to see a dentist, there were some respondents that did respond at a significantly higher age range, 4 years plus with those 5 respondents. And again, that points back to the importance of just health education in general for the importance of age visits, not only for dental and oral care, but also for just pediatric care in general. Slide, please. So I wanted to ask a very open-ended question in our survey, and that was, if you were given a magic wand, what is one thing you could do to improve pediatric dental care? Now, this was just a small snippet of the comments that we received. All 39 individuals that took the survey currently, as of earlier this week, did leave a comment of some sort. I tried to keep it with the most important or pertinent that I felt. Of course, having dental checks in schools was one of the answers that we had. More affordable and accessible hours was another. Transportation, of course, we noted that earlier in the presentation as being very important. As you can read down through the list, having to go to Baltimore for wisdom teeth being pulled is a significant barrier to care. Someone wanted some mobile dental care in certain communities, thinking that that was a way to solve the issue. And you can read down through the list. And of course, we'd be happy to share these slides and comments. But, you know, overwhelmingly, everyone that took the survey did have some sort of feedback as to what they envisioned would be something to improve dental care, but also just some complaints as well as some of the barriers that not only do they see, but also that impacts their family as well. Slide, please. We did ask if you are familiar or if they are familiar with the Maryland Healthy Smiles Dental Program. On the survey, we did actually list out what that entire program was in its entirety. And again, over majority did say that they were familiar with the program, but again, 8 individuals had no idea as to what the Maryland Healthy Smiles Program is, which again then points back to having the proper education for individuals. Slide, please. Do children in your community receive school dental screenings? Overwhelmingly, yes, the majority did say yes, that they do receive some sort of dental screening in school systems. 4 said no, and 14 were unsure. Slide, please. Then we had them rate their own children, how they perceive their own children's oral health care. 3 respondents said they had fair oral health care. 6 said good, and 13 said very good. Now, as a nonprofit executive director and someone who advocates for a lot of different healthcare needs in Maryland, I would want that number to be very good for everyone. But having their own parents who took this survey indicating that their child's oral health is fair or below, or even good and below, it's actually kind of alarming to me. Seeing these numbers, even though it's a small amount of the survey respondents, it's still very important to note. Slide, please. And then one of our last questions that we asked in the survey was, do you have dental coverage, including if you have children, do you have dental coverage? 4 respondents did say no, and 35 did indicate yes. Now, again, that's fantastic that the majority did have some sort of dental coverage. But again, it is alarming that 4 respondents did not have any dental coverage at all. Again, the slide, please. Before I hand it back over to Dr. Koyman to talk about some solutions to the barriers, again, the survey is continuing to be ongoing. We will be soliciting some more feedback at our conference here in the fall, and of course on social media as well. My intentions are to get some more community-based feedback. The majority of respondents were from healthcare background, and so we again will be happy and able to share some more data as we continue to collect. Dr. Koyman. I believe you're on mute.
Thank you. That was amazing, Jonathan, that you were able to put that together. And I think, the more data that we get on that, the, more interesting it becomes, because, it being just mainly healthcare providers and people that are in sort of this arena, and just the wide variation that you get as far as answers, when you think down to the community level, just the, a person that has a new child, or, their first child, or, they don't know these things, they don't know what to be looking for. I mean, it's a daunting thing sometimes. So anyways, getting to solutions to some of these barriers, when it comes to transportation, I guess these are, again, I can't give you specific, solutions, but I mean, some of these are lofty goals and just ideas. And I think that's what this task force was built to do, was to put ideas out there and see what sticks to the wall, and see what maybe we can improve on, as we move forward out of this. Maybe using the transportation budget to, have patients, be able to use Uber or Lyft drivers in metro areas, or giving them toll vouchers, if they're coming across the bridge or using the tunnel, to get to an appointment, and even some sort of gas card voucher, if there was a way to do something like this, at the state level, I mean, I think the budget could be used maybe more efficiently or creatively, but just some ideas on that. Slide, please. Workforce. So I think this is something coming out of this task force, is one of the things that I would really like to see change or happen. Of course, significant fee schedule increases. We had a minor 9.6% or 7% fee increase with Medicaid recently, but there's concerns with the adult population coming on that no new fees were added to the fee schedule. And still, the fee schedule is really low compared to a lot of the fee increases that are going on in other states. Looking at our state to the south, Virginia, which recently just passed a huge increase in their Medicaid funding. More expanded function for dental hygienists, more expanded functions for dental assistants. increasing education programs for assisting and for dental assistants and for dental hygiene. I think increasing that workforce is going to be critical. Slide, please. This I really think is a way to solve how to get providers into rural areas. You know, expanding on the LARP program, which is a tuition reimbursement program now, which I believe gives back up to $110,000 or $100,000 for a 3-year commitment to see Medicaid patients. But you know, these kind of full tuition scholarships could be given to both dental hygiene and dentists over a multi-year commitment to practice in areas of need. You know, I said it on the earlier one, but I think, you know, I look at this like the Navy scholarship or any of the armed forces where they go into dental school and they commit to working for the armed services for 3 years, and their tuition for dental school is paid for by the military. This could be something that we could do at the state level, where with the rising cost of education for both dental hygienists and dental dentists, you know, having some sort of tuition scholarship, you know, to say, I'm going to have you work in Allegheny County or out on the Eastern Shore, and I need like a 3 or 4 year commitment from you to see whether it's in an FQHC, whether it's opening a practice, things like that. But being able to get providers in those areas. And the hope is not everybody's going to stay, but just like in the military program, most people plan on going into it and just doing their 3 years and then getting out. But there's a big percentage that decide that, you know, I kind of like this and I'm going to stay in this area. I'm going to stay in the military. And I think if we could somehow create a tuition reimbursement or a scholarship program to get dentists to move to these areas of need, you know, you're going to have a percentage that may lay roots down and actually stay there and open a practice, raise their family, and be sort of a provider in that area. Other ideas, I mean, you know, offering some sort of grants to providers to open in areas of need, you know, either 0% loans or some sort of payback, you know, after they open up based on the number of, you know, Medicaid patients they see. Because, you know, as the field of dentistry is changing, meaning as more and more dental service organizations are now buying up practices, you know, my concern a little bit as we're looking forward, you know, 5 to 10 years, DSOs are buying up practices for just say pediatric dentist practices, and I think in general dentistry too, but a lot of pediatric dental practices, but they're buying them up in metro areas. They're not buying practices in rural areas. They're not interested in that because they know that the residents and dental students that are coming out of school, you know, want to go to these areas. My worry is that as more dental service organizations capture more practices, you know, there's going to be fewer and fewer graduating dentists or residents that are going to be going into rural areas. I mean, they want the ability to kind of go into a metro area and work for somebody, and then, you know, in 3 years, if they want to move to Nashville, the DSO that they're working for says, that's great, we have an office in Nashville for you. And that's good for the metro areas, but it's really bad for the rural areas because that's not the DSO focus. So, you know, if we can move people by giving them tuition reimbursement in these areas, you know, they will maybe be able to access or provide access and get rid of some of these barriers. And at the same time, maybe be opening their own offices and starting a business in those areas. Next slide, please. Operating room access is a big thing too. I mean, there needs to be increased reimbursement rate for anesthesia. I mean, as of right now, dental cases are not paid at the same rate that medical cases are. So, you know, there needs to be some sort of normalization as far as that goes. Increased dental surgery centers. I mean, it's more efficient than the medical centers are. You know, there's 2 that we have now in Maryland, and they're doing really well. But it could be a way to offer greater access to dental care under general anesthesia. And, you know, another one would be increased reimbursement rate for in-office anesthesia. There are several anesthesia groups across the country that will come into the office and deliver anesthesia safely in a dental office. But they will not participate with Medicaid because the reimbursement rate is not there. And if we could move that needle and capture some of these providers to offer those cases, you know, you'd be able to treat a lot more patients in their dental home in these specialty practices, rather than having them go to a hospital and take OR time from other cases, and be at a greater cost to what the state pays for those cases. Meaning, you know, when they're paying for the facility fee and everything that goes into the hospital is way more expensive than it would be to pay for treatment under a surgery center or even as an in-office anesthesia type model. Slide, please. And probably the biggest thing is just education. I mean, all these things that we talk about still go back to education. You know, I mean, if we can concentrate on education, you know, hopefully we can, you know, provide parents with more healthy diet and food options, make them realize the importance of baby teeth, the importance of the age 1 visit and prevention and how key that is. You know, all the things that we talk about as far as operating room access care and increase in fee schedules and these things, you know, if we're working with prevention in the beginning and educating parents on how important it is to take care of their child's teeth, how important it is for them to see the dentist at age 1, because we can give them a dental home and give them the information that they need and, you know, give them a place that they can go to. So if little things start to come up, that we can manage those little things before they become big things later on down the road. And another thing would be, you know, a possibility would be to recommend or mandate an age 1 dental visit, which would be in line with our medical professionals. I would like to just take, you know, 5 minutes here to just have Dr. Booker talk about this really quick, because as the incoming MSDA president, this is she's very passionate about this age 1 dental visit. And Dr. Booker, if you'd like to take a moment.
Absolutely. Thank you so much. And thank you for all of that information. That was a very comprehensive overview. So thank you for that. Do you want me to screen share these slides I have? This is just 10 in the deck. Do we have time for that?
I would say yes, please.
All right. Thank you. Let me see here if I can go to that. Oops, let me show this. Oh. Is it going to let me do it? So, okay, here we go. I think I'm clicking here. All right. How can I get to the screen share here? I don't see the option right this moment.
Do you have a toolbar along the bottom of your screen?
I
where
do.
Participants chat. You have a share screen.
I'm looking for the
icon?
share screen. I don't see it here. It's not showing up. Let me see.
Madeline, are you there? Have you made Dr. Booker a co-host so that she can share her screen?
She should be your co-host. Hold on 1 minute.
So while we're doing that, I'll just talk a little bit, but it dawned on me when this time of the year, or it probably starts back early July, when parents start coming in and they want those school forms filled out for their kids. And many of the forms, a lot of parents are in a panic about it, and the children haven't actually been into the office perhaps, or they still have ongoing treatment. And it dawned on me that we're sending these children, these are the very children we're sending to school with this massive decay. And as Dr. Koyman talked about earlier, we, as the American Academy of Pediatric Dentistry, we've been promoting this age 1 dental visit for the last 36 years. But yet we have 74% of parents, as he said, that are not bringing their kids. So that translates into only about 26% of parents that are actually bringing their child to the dentist for that age 1 dental visit. And these are the kids that we are taking to the operating room that had this massive decay. So when is this early childhood caries occurring? It's occurring while they're in daycare or in family care at ages 1, 2, and 3. And then now it's time to go to preschool and they have this massive decay. If we can show these slides, let me see if I can come up yet. I'm not seeing anything where I can share the screen as of yet. Nothing yet. It says read the blog. Let me see. Chat. Let me see here.
There should be a toolbar along the bottom of your screen. Mine has security, participants, chat, and then share screen is the next icon.
I can see chat, but we don't want that one. We want the next one, right?
It should say share screen.
That one doesn't say share screen. Let me see. Office.
Alternatively, if I could get you to quickly email me your slides, I can share them from my screen.
Okay, it looks like that's what I'm gonna have to do. Let's see.
Here, I'll send you my email address. Oops.
Is this Lindsay?
Yes.
Okay, let me see, Lindsay, inbox. Okay, did you send it?
I just, in the chat, I just sent you my email address. Look in the chat.
Okay, let's see in the chat. I'm gonna have to maximize this and go to the chat here. Okay, here we go. Sorry about that, everyone. Just a second.
Dr. Koyman, would you like to finish up the other slides that you had, and then we can maybe
Sure.
return to Dr. Booker?
Thank you so much. Paste.
So what I was saying is, by recommending or mandating an age 1 dental visit, this would allow us to get these kids in early, before they go to preschool, like Dr. Booker was saying. The more kids that we would get in at age 1 would allow us to screen these children, educate these parents, and give them a dental home where that way we can start seeing them at 6-month intervals and, watching them and making sure that they're growing and developing normally. Slide, please. Legislation, I know legislation is difficult when you do anything. And this is a little bit off of one of Dr. Booker's slides, actually. But, children enrolled in daycare between the ages of 1 and 4 would need to provide recognition of a dental home. They would need to confirm that an age 1 dental visit had been fulfilled and recommend, follow-up visits are satisfied. This would be consistent with the expectations of the 9-month to age 1 well baby visits, and would also be consistent with our nation's EPSDT as far as, medicine goes. I know trying to legislate anything is not an easy thing to do. And of course, I don't want to make something that creates more barriers to care. But I think education and making this be something that parents understand is really, really important. You need to have this done for your child. And I think the messaging has always fallen a little bit flat on its face. I don't think we've ever really had it out there, to educate parents the importance of the age 1 dental visit from the state of Maryland or from the Academy of Pediatric Dentistry. I mean, we say this, but it's never been a full out media thing. And, maybe by making it something that you need to have this done before your child can, enroll in any daycare, Head Start program, things like that, would be good. Slide, please. So again, the goals are you know, as we move forward, trying to increase reimbursement rates so we get more provider participation, institute an age 1 visit, expand tuition reimbursement to both dentists and dental hygienists, increase anesthesia fees for GA, and coming up with alternative general anesthesia models, and trying to revise the transportation model. I mean, I think there's transportation has moved in a totally different direction since when we first provided transportation. And I think using some of these other models may be fiscally a little bit less expensive and maybe easier for our parents to access. So that was what I had. And if Dr. Booker's presentation is there, I will turn it over to her.
Thank you. And it's a perfect segue. As I was sharing before my slides wouldn't come up. Were you able to get them, Lindsay?
I still haven't received anything.
Okay, so let me see if I can do it now because I see the screen share option and here we go. I did send it though, so let's say share here. Can we see it now, everyone? Okay, we have it now. Okay.
Yes.
So if we look at the faces of these children, what are we talking about? What's so unbelievable? How did this happen? What's so scary? And it's gotta hurt. So this is what we are talking about now. Am I in screen? So this
Finally,
is right.
this high-chair dental care should have your consideration.
Oh
and
no,
support.
let me stop
How
sharing. Let's see. I don't know what happened there. I'm sorry, everyone. Let's see. Can you see the slides now?
No,
Can
you have to reshare it.
Okay, I'm gonna go past that one. Let's see. Oh, gosh. I don't mean to hold everybody up. This is a disaster for me. Where are we? Okay. Let me see. Okay, I'm gonna try it again. And share. And then we'll go. So this is what we're talking about. So I've come up with what I believe is an innovative way to help to move the needle on getting parents into the age 1 dental visit. So these are the kids that I'm seeing that we're sending, and many of pediatric dentists are seeing that are age 1, age 2, but we're sending these same kids off to kindergarten and first grade in this condition because they're not getting in for the age 1 dental visit. So we're completing those forms because in some counties, as we know, they require those forms to go to Head Start or to go to school. But yet we're still seeing this disease because I think we're missing it, or I know we're missing it. And I think that most pediatric dentists that are seeing kids that have early childhood caries would agree. So, okay, trying to move the slide now. Everybody's on this slide, this same slide?
Yep. If you just hit one of your arrow keys, it should move it to the right.
Okay, I did that. It's seeming like it's frozen.
How many times do we still, in 2021,
now? Okay,
Dr.
here we go.
Booker,
So we've already talked about this. And so for 36 years, the American Academy of Pediatric Dentistry, the ADA, the Academy of General Dentistry, and the American Academy of Pediatrics has promoted the age 1 dental visit. But I think we all agree, who are dentists on this call, we didn't learn anything in dental school about how to treat that infant or toddler. So that's also a part of what the disconnect is. Because not only are there not enough dentists that are willing to see the age 1 child, we're not even really trained to see that infant toddler until you go to a residency program. And we know that pediatric dentists are few and far beyond. We've already talked about this slide in terms of what our millennial parents are doing. So we know that only 26% of them are actually getting that child in for the age 1 dental visit. So what I decided was I became very frustrated by all these kids needing to get this form filled out, but yet we're sending them off to kindergarten, first grade, preschool with a lot of decay in their mouth. So it dawned on me that if we are having to get children ready to go to elementary school and complete this form, why aren't we doing the same thing for daycare? And so I put together a daycare ready oral health care certificate to give to my patients. So when they come in for that age 1 dental visit, they get a certificate. And what that means is the certificate says that the child has an established dental home, that the parent or guardian has been given a record of this visit, and that they can share this record with the daycare provider and with the pediatrician so that everybody's on the same page. Dr. Corman talked about interprofessional relationships. And to me, that includes the daycare provider, because a lot of times the daycare provider, it has been my experience at least, when we talk to parents about how did this early childhood caries happen, and the parents will say, I don't put them to bed with the bottle. I don't, give them juice. I don't give them candy. They get that at the daycare. So I've heard that scenario many times. And so as we've discussed, as Dr. Quimman said, it goes all the way back to education. So how does this work? What I'm proposing, and I would hope that we could move legislation forward sooner than later. And as you know, a member of the Maryland State Dental Association, soon to become president, I have shared this presentation with them last night. And my thought is to establish a state of Maryland infant and toddler oral health daycare enrollment policy, that in order to go to daycare, just like in order in some counties to begin pre-K or kindergarten or first grade, you have had to have that form filled out in order to do it. And that, once again, having that form aligns us with our physician colleagues. Head Start does a great job of requiring that form. You cannot go to Head Start unless you've had a dental evaluation. So how would that framework of legislation look? It would require, again, the dental home, that it confirms that you had the age 1 dental visit. It deems the recommended follow-up has been addressed. And we have been talking about, and you all probably can tell me better, for the last 10 years, value-based incentives. And what my value-based incentive is that I give to my parents in my infancy of doing this so far is that I provide them a certificate, and I'll show you that in just a second. I didn't get to share this with you to send copies to you, and maybe we can later, but the state of Maryland requires to go to school this health inventory. And on this inventory, it's a 5-page document. And the first part of it is for the parent to fill out. And it asks the parent the assessment. It asks about asthma or breathing. It asks about your eyes. It asks about feeding. It asks about lead poison exposure. It asks about speech and language, nothing about dental. So then you go to the next page of it, and part 2, the child health assessment has to be completed. And the persons to complete this are the physician or the nurse practitioner. And here it does ask about dental, but it asks, is it within normal limits? Has it been evaluated? So it's a check off. But then there's a whole form for lead exposure. So they have to have all these forms filled out, but no dental. So I would propose that we also expand the requirement, as was talked about in Dr. Corman's presentation. I also suggested that should legislation be introduced, that maybe this is what we want to talk about. I won't belabor this point because I think maybe perhaps it's premature. The Maryland State Dental Association is discussing introducing a resolution. But this is why it's important. And this is going over some things that have already been said, but we want to be consistent with the 9-month to age 1 well baby visit. Why not? They have teeth already. And it supports, doing something like this supports the EPSDT. And, having this certificate, is an alignment with, certifying that the child is daycare ready and they have had their teeth checked. This is what Head Start requires. You cannot go to Head Start without the dental form. And this is what it says. So this is what I give to my parents. This is my value-based incentive for my parents. They get the certificate. They can either hang it up on their walls or put it in a scrapbook, but they can also utilize this to share with the physician and as well the pediatrician. So now it's all a part of their record. So what I'm proposing here is that we get our youngest Maryland citizens daycare ready, just like we get them ready for elementary school or preschool. I'm happy to answer any questions. I appreciate you giving me the time to share this thought and idea, and I hope we can move this forward in our state. I have shared this with the American Academy of Pediatric Dentistry. They're pretty excited about it, and hopefully we're going to get some movement, and not only here in Maryland, but nationwide with this.
Thank you, Dr. Booker. And I just
Thank you,
want to thank
guys.
everybody for you guys' time. And sorry it went over a little bit long, but I'll open up the floor if anybody has any questions.
Thank you all so much for your presentations. We do have some time constraints. There are others that need to get off the call, that need to present. So if people could just put any questions that they may have in the chat, that would be helpful so that we can move along.
Thank you.
Thank you. So next, we'd like to give our adult subgroup time for their presentation. So Dr. Verma, Dr. Kimbers, if you all are ready.
Thank you so much. Really appreciate the comprehensive presentation on pediatrics and having Dr. Booker here to provide some guidance as well. The thing about following up a really comprehensive presentation is you never look as good. So I'm just going to warn you guys ahead of time that our presentation is considerably shorter. Dr. Kimbers and I have spent some time working on this. I'm going to turn it over to him to start it off, and we'll try to keep it as brief as possible.
Okay, good afternoon, everyone. I'd like to first start by thanking Dr. Hughes for giving me some information that I'm going to start out with, and that was the history of the Maryland Medicaid program in the state of Maryland, and she was very responsive, and I do appreciate that. Thank you. The state of Maryland is celebrating its 50th anniversary of Medicaid program. It provides medical and dental coverage to over 1 million Marylanders who qualify, including children, low income, the disabled, pregnant women, and seniors. The Affordable Care Act of 2010 triggered the state of Maryland to create the Maryland Health Exchange, a marketplace that became Maryland Health Connection. The ACA allowed even more low-income adults to become eligible for Medicaid. The American Dental Association is the leading stakeholder in urging Congress to extend coverage to millions of low-income adults with the Medicaid Dental Benefit Act. If passed, the bill would make it mandatory for state Medicaid programs to cover adults, thereby increasing the amount of federal funds to each state. The letter sent by the ADA and other stakeholders in support of the bill states that access to dental care benefits have worsened due to COVID-19 pandemic, as we already know. This has caused an increase in Medicaid enrollment and millions of delayed dental appointments. The current system does not guarantee coverage for adults over the age of 21. Maryland is one of 3 states that does not currently have comprehensive coverage for adults, but luckily, on January 1st, 2023, Maryland will join the other 47 states with coverage for adults. CareQuest, an informative and informational gathering nonprofit component of DentaQuest, presented the State of Oral Health Equity in America 2022. In this survey of over 5,000 adults across the nation, it was noted that, number one, 96% of adults realize the connection between the health of the oral cavity and the rest of the body. That's pretty high. Number 2, more adults said that finances were a reason to avoid future care in 2022. And that number for in 2022, it was 43%. That number in 2021 was 38%. So the more adults saw that finances were a reason to avoid future care, and it's going up. Number 3, socioeconomic disparities in the oral health setting contribute to discrimination and racism in the African American, Native American, American Indian, and American Indian communities. And number 4, emergency department visits by African American adults and American Indian and Native Alaskan adults are 2 to 3 times more likely to visit the emergency department for a dental problem than are white adults. Over the past many months, we have been discussing how closely tied oral health is to overall health as well as psychological health. The American Medical Association Journal indicates continued separation of dental and oral health from general medical care exacerbates inequity and forces members of underserved communities to seek non-traumatic dental emergency care in hospital emergency departments. This trend is unnecessarily costly and results in antibiotic prescriptions and pain management that are neither restorative nor responsive to patients' primary complaints. In CareQuest's 2020 report, researchers found that since 2014, the average annual charge associated with emergency room dental visits have increased by 62%, with an average emergency dental visit resulting in fees averaging $1,643, as opposed to average fees for the dental practice at $90 to $200 for a similar visit. Patients most likely to visit the emergency department for a non-traumatic dental condition are ages 25 to 34 years old, uninsured or having Medicaid coverage, live in a rural area, or have an income below $48,000 per year. Black individuals were 44% more likely to visit an emergency department for these issues compared with white individuals. These trends reflect changes and growing inequities in Americans' access to dental care. I'm going to hand it over to Dr. Verma. That was just a quick overview, and she will take it from there.
Thank you, Dr. Kimbers. I appreciate that. We all know that there's a reflection on oral health from general health. Infection, pain, fractures, loss of teeth, and poor oral health definitely affects your general health. For example, things like nutrition, quality of life, obesity resulting from poor oral health, diabetes, metabolic disorders, cardiovascular diseases, Alzheimer's disease, and dementia have shown to be related. Rheumatoid arthritis, and there are several cancers that are related as well. In addition, oral health can certainly affect the way someone sees themselves. It affects your self-esteem, can lead to anxiety and depression, which has also become exacerbated because of the pandemic. It tends to inhibit social interactions. Patients tend to be embarrassed to interact with others when their oral health is not what they would like it to be. It obstructs the ability to interview or obtain employment. Many employers are not trying to be, but are turned away by people who don't have the best oral care or the ability to have missing teeth, et cetera. It may obstruct their ability to obtain employment. And those employed in lower socioeconomic jobs frequently do not have dental coverage for care anyway. So some of the barriers and obstacles that we have found, especially for those that discourage Medicare providers, patients with in this particular category tend to have very complex cases, frequently as a result of having had poor care over a lengthy period of time. They can have issues that range from things like bone loss, infections that hamper the ability to treat them, frequently removing posterior teeth due to extractions because it was the most expedient thing to do can result in bite collapse for the patient, All of that makes it really difficult to provide restorative or rehabilitative care to these patients. There's also a limitation in services that is provided for coverage under Medicaid. For example, dentures or crowns aren't covered, and many of these patients are really in need of those types of services. The reimbursement rates, unfortunately, have not kept pace with inflation in lab charges or dental healthcare personnel salaries. Those expenses also make it more difficult for providers to accept the Medicaid rates and be available for these patients. Dr. Doring has discussed this, and I've faced this as well. There's difficulties with credentialing and re-credentialing providers. It's a complicated process. It creates a lot of frustration, and it tends to discourage providers from applying or re-upping their credentialing with Medicaid. The reimbursement times are also significantly longer than traditional indemnity insurance plans. And of course, patients in this category tend to have more failed appointments as they have difficulty with transportation. They may also have non-working or no cell phone availability. So reaching them to verify appointments or confirm appointments can be really, really difficult. So some of the recommendations that we are making for our thing is to increase the number of Medicaid providers. Dr. Koyman had some really good suggestions as well, especially in underserved areas. To create a reimbursement for procedures like dentures that allow some rehabilitative care for these patients, really to reconstruct the jaw to make it both functional and aesthetic for them. To improve coverage for plans in all areas. Everyone should be entitled to dental coverage that provides all the basic aspects to restore optimal oral health. And of course, to increase the outreach and education, and has been discussed multiple times. So that brings us to the end of our presentation for the adult group.
I just wanted to mention one thing, that all of us should see that we're all basically saying the same thing, no matter what the age of the patient is. It's the same problems, basically the same problems. So, and we can all see that.
Thank you all for the presentation. If we could hold questions until the final presentation, I'd appreciate it. Or if you like to, as I said before, you can put a question in the chat. So next we will have Dr. Carlson present for our subgroup on immigrants. If you'd like to proceed, please.
Thank you. I'm Dr. Jean Carlson, retired general dentist on the Eastern Shore of Maryland, and currently teach at Chesapeake College in our dental assistant program there. Our subgroup was tasked with looking at the barriers to care and recommendations for improved access to care to undocumented immigrants. It's interesting to say that the system is not designed for you when you are not part of the system. So that's what we'll be addressing in the issues of this population. Next slide, please. We find that when we look at this population, words really do matter. There are many terms that are applied to people who enter the country without authorization, or who have entered the country lawfully but maybe stayed after their visa or status expired. Terms like illegal immigrants, unauthorized immigrants, undocumented immigrants, illegal aliens, living or entering US illegally, undocumented non-citizen, undocumented American. All of these terms come with various ambiguities and value-laden connotations. In other words, there is judgment that can be insidious behind these terms. They matter because they do refer to people. They're not particularly neutral or impartial descriptions. They can be insulting, they can be hurtful, they can be judgmental. The words that we use to describe these different types of immigrants reflects our vision of a just immigration system. Next slide, please. We need to begin with the unfortunate and unavoidable conclusion. After we've examined the barriers to care faced by undocumented immigrants and the potential solutions, we have to conclude that undocumented immigrants are unable to access or utilize the healthcare system in the United States. And this not only puts their healthcare at risk, but the health of their families and the general public. Next slide, please. In the United States, there are approximately 44 million immigrants, and about 11 million of those, or a fourth of them, are undocumented. The largest immigrant population comes from Mexico, with also significant populations from China, India, Philippines, El Salvador, and the other 54% approximately come from other countries. Most of these immigrants live in California, Texas, Florida, and New York, and 53% of them, or almost 6 million, are uninsured. So you can see in the graph there, the states in red would be where the majority of immigrants live in the United States. Next slide, please. In Maryland, we have 915,000 and a little more immigrants in Maryland, which comprises about 15% of our population. About a fourth of those are undocumented. The undocumented immigrants comprise 29% of our immigrant population and about 5% of the state's total population. Most of these people work in the construction, hotel, or food service industry. We find that the largest percentage of people come from PG County, Montgomery County, and Baltimore City to a lesser degree. Next slide, please. The barriers to healthcare for undocumented immigrants. We're going to look at these on 3 levels: that of health policy, health systems, and individual. Next slide, please. In terms of health policy, these are the policies that are designed to, unfortunately, bar access to health insurance by law. They end up being designed to disincentivize immigration. Undocumented immigrants cannot obtain insurance through the Affordable Care Act. Our health policy currently limits access based on age, income, and type of health care. General health care, but not oral health care, is included for some. Age limits, children, seniors, pregnant women, these things are limit care. Income restrictions, of course, Medicaid has income restrictions that end up limiting care for people. People need to show documentation to get services. So undocumented parents tend to avoid care for authorized children because of fear, obviously. The health system barriers, and this would apply to providers, places of care. The barriers here would be cost. We all know that without insurance, healthcare costs can be prohibitive. External resource constraints would include things like fear of getting fired for taking time off of work, not having the transportation, which we've talked about with all the subgroups, language skills and lack of translation services certainly represents a significant barrier to care. The complicated bureaucratic obstacles, paperwork, registration systems, again, the language barrier is a big factor here. Lack of cultural competency. As our speaker from the Eastern Shore here told us, in Guatemala, where many of our immigrants come, seeking regular medical or dental care is not part of the culture. Seeking care when you are in pain or have a life-threatening situation is appropriate for them in their culture. There also has been some evidence of discriminatory practices among providers, and safety net clinics offer care, but a lot of times these are sporadic. They're overwhelmed and they don't address all of the issues that these people may have. On the individual level, there is certainly a mistrust of the system and fear of deportation. Many people report avoiding regular health care and only seek it when it's absolutely urgent because of this particular fear. There's the communication ability, as we talked about, language skills, lack of financial resources, and a shame or a stigma. People feel that they would be a burden on the system, or that they would be stigmatized if they sought services. And finally, just knowledge of healthcare system. They don't know how to navigate our healthcare system here. Next slide, please. So the ability to access dental insurance for undocumented immigrants is very rare throughout the entire United States. When and if it does happen, it's often part of a broader health insurance effort or package, such as California, which I'll discuss in a moment. It can be based on specific conditions or circumstances, for instance, dental care for children or pregnant women or people 65 and older. Dental insurance is available to undocumented immigrants through a very limited number of private insurance companies. Next slide, please. How people access care in the United States. There are 4 basic ways here: through private insurance, and some private insurances accept undocumented immigrants, not many. The cost, of course, can be prohibitive. It's unavailable through private insurance in the workplace to many undocumented immigrants, of course. The Affordable Care Act requires one to be a US citizen. Medical and dental insurance is unavailable to undocumented immigrants then. States can seek a waiver through the federal government, and some have, that we discovered. Medicaid, undocumented immigrants are excluded to Medicaid in almost all states, and also income qualifications are in place here as well. Medicare applies to those 65 and older. It does not currently include dental care, which is something that is being addressed, hopefully. One must be a US citizen and have legally worked in the United States and have paid into the Medicare system to access that in any case. Next slide, please. The dental safety net. Safety net for dentistry would include clinics and events, but these really offer just varying degrees of dental care. They're sporadically located. Oftentimes they're overwhelmed with limited staff. People have to wait a long time to get an appointment. Sometimes they wait in line overnight at various clinics and services. The services that are provided are limited. They're usually free or sometimes based on a sliding scale payment. Safety net clinics try valiantly to perform their job, but it's not a permanent or long-term solution. Safety net services in Maryland would be such as Catholic Charities, Esperanza Center, Healthcare for the Homeless, local health departments, and FQHCs, the federally qualified health centers, such as Total Healthcare, Chase Brexton. Also, we have Chop Tank here on the Eastern Shore. And of course, Missions of Mercy. These are frequently overwhelmed, and again, people waiting in line for hours, and it's not something regularly held, so it doesn't really provide the kind of care that these people need. Next slide, please. In California, we have something that's very interesting that happened recently. Governor Newsom signed into law the first in the nation Medicaid expansion for undocumented immigrants aged 50 and over, including dental. So we ask ourselves, how did this happen? Well, it was kind of the perfect storm. California does have the largest undocumented immigrant population in the nation. These immigrants, most of whom are farm workers, are absolutely essential to the California economy. The pandemic reinforced the need for health care. There had been 10 years of strong legislative advocacy. California was in the middle of a booming economy. The right leadership was in place, and dental care was able to ride in on the coattails of a larger healthcare initiative. Next slide, please. In New York, from 2021 to 2022, an expansion of Medicaid for undocumented immigrants has gained some traction in the New York legislature. On April 12th of this year, Medicaid expansion became law, but it was less than hoped for. They have managed to succeed. They have managed to obtain access to Medicaid for undocumented individuals 65 and over. They have a migrant worker program that provides dental coverage to undocumented farm workers. And this has been in existence for years. It came about because of the importance of migrant workers to the farm economy. Also in Indiana, we discovered that undocumented immigrants are only eligible for Medicaid Package E, which means that Medicaid covers no dental care unless it turns into an emergency requiring hospital care. So that's another state example. Next slide, please. The states that offer access to health care for the undocumented, well, there are 6 states plus DC that have inclusive healthcare policies for immigrant children. And you can see that these are the states highlighted in blue: Washington, Oregon, California, Illinois, New York, Massachusetts, and DC. In Maryland, we do have the Healthy Babies Equity Act, which passed the General Assembly in March, and that expands Medicaid to cover prenatal and postnatal care to pregnant people regardless of their immigration status. Okay, next slide, please. Sometimes special circumstances allow immigrants to obtain care. For instance, currently we've got the benefits for Afghan humanitarian parolees. This includes Afghani individuals that have been granted humanitarian parole by the Department of Homeland Security between July 31st of 21 and September 30th, 2022. And this was issued in response to their need for the rapid evacuation and relocation under Operation Allies Refuge and Operation Allies Welcome. Next slide, please. So the strategies that we would recommend to address access to dental care for undocumented immigrants. The potential solutions we feel to this problem can be found in 5 main categories. The first, through advocacy and policy change, insurance options, expanding the safety net, training providers to better be able to care for this population, and education on navigating the healthcare system. Next slide, please. Under the heading of advocacy and policy change, we recommend changing law to provide access to care regardless of citizenship. On the national level, this would apply to the Affordable Care Act. On a state level, this could be applied to Medicaid. And these changes could be for full, partial, or special case access, such as pregnant women, which we've already begun to address prenatal, postnatally. Insurance options, we recommend creating special insurance programs through the state. For instance, a standalone program providing a dental option in the Maryland Health Benefit Exchange. It would be interesting to see full insurance benefits to employees regardless of immigrant status. And it's possible to require undocumented immigrants to contribute financially, even if this contribution were small, would still cause them to have a feeling of investment in their healthcare. Next slide, please. For recommending access to care improvements under the expansion of the safety net, most of these safety net clinics do not have the capacity to provide care to large numbers of people, and they would need to have increased state support. For provider training, providers need training to deliver appropriate and culturally sensitive care, such as the cultural competency training that we've gone through. Navigators and cultural ambassadors can help these people navigate the healthcare system. For education and outreach, we would recommend educating to facilitate utilization of the healthcare system to the undocumented immigrants, and also educating them so they understand policies relevant to the access to care. Next slide, please. That would be the completion of our presentation. I don't know if we want to take any questions or discussion right now. Dr. Hughes, if you have anything that you would like to add to that, Dr. Hughes?
No, thank you so much, Dr. Carlson. It's been a pleasure working with you on this presentation. So I think now we do have time to allow any questions from any of our subgroups. I see that let's see. Dr. Doring had a comment in the chat that I'll read. The prevention of early childhood caries will take a village. One collaboration should be with the Maryland State Department of Education, Office of Child Care. Their child care and nursery school health inventory was last revised in June 2016 and needs to include oral health as a suggestion. Dr. Doring, is there anything else you'd like to add to that?
When I say a team, I'm looking at the whole dental community, certainly advocates for oral health, dental hygiene members. They certainly play a part in outreach. Some of this, we talked about transportation for kids. Why aren't we outreaching more to schools? Look at the model being done, say, in Anne Arundel County through their health department, or Chop Tank, where they go out into the community. Yes, the guardian or parent signs off on consent, but they're consenting for all kinds of medical evaluations. So I think there are some present models that we can look at. Head Start, for example, model these, and then certainly talk to where we've run into problems when we don't reach out and talk to the medical community and education people. So we certainly want to include those in these discussions, and those were just my thoughts.
Okay, thank you. Dr. Romaine, I will read your question. It is for Dr. Verma. Yes, she's on the call, still on the call. On the issue of workforce, which has been a consistent thread through all of the subgroup presentations. Last year, our Maryland State Legislature passed a bill to expand the duties of chairside dental assistants to expand access to care and perform additional duties, such as applying dental sealants, silver diamine fluoride, monitoring nitrous oxide, and polishing teeth. The Board of Dental Examiners has been charged with developing educational and testing requirements for the expanded function dental assistant status. Can you please comment on the progress, Dr. Verma?
Yes, thank you so much. I apologize for being off camera. I'm trying to drive to another appointment, so please forgive me for that. I appreciate the question. The legislation that was passed this past session was very broad, very large, and has very large consequences. The board is currently promulgating regulations to meet the requirements in the legislation. But I'd like to take a moment to just give a brief overview of the process. So once legislation has actually been passed and that's sent to the Maryland State Board of Dental Examiners, we have to take that legislation and turn them into regulations, which essentially allow guidelines around how that legislation is actually utilized. That can take a considerable period of time, but we've been given a short, brief 5 months to come up with a considerable number of regulations around not just the things that these assistants can do or this workforce can now do, but also the educational requirements, the certification and the renewal process for those workforce employees. Once the board has completed the promulgation of regulations, which is due by October 1st, if I'm recalling correctly, those regulations then have to go to the Secretary's office for review. That process in the last several years has become very, very lengthy. It typically used to be a 6 to 8 month process, but we have regulations for dental hygienists to be allowed to prescribe certain types of medications that have been pending now for 24 months. So until the secretary signs off on those regulations, and now there's a new caveat that it has to go to the governor's office for their sign off as well, that cannot actually be put into force. So unfortunately, it's not in our lap as far as moving that forward. We are working very hard We've been working on those regulations for quite some time, ever since the legislation was passed. We are hopefully very close to an open comment period on the regulations, because we'd like to invite the dental community to provide some input on that. And then they will go to the Secretary's office. I wish I was clairvoyant enough to know when those would be potentially signed, but my ESP, as usual, sucks quite badly. So unfortunately, I don't know when that might be passed. So we could potentially, and with the changeover of the administration, that's going to cause, unfortunately, some delay as well. At this point, it's kind of a waiting game once we send it over to the Secretary of Health to see when that will move forward. I wish I could have a time frame for it, but I hope that answers Dr. Romain's question.
Thank you so much. Dr. Booker, you have a question? Dr. Booker, your hand is raised. Do you have a question? You can't hear me?
Her screen may be frozen.
Oh, okay. All right, until we can figure that out, does anyone else have any, Dr. Doran? I can't.
You're on mute.
Okay.
Thank you. Everyone's presentation was excellent today. So thank you so much. I just wanted, for the adults, I just wanted to stress, and it was said during the presentation, and I'll say it again, and it was when we had Marco from the ADA do his presentation last time, the adults to extract teeth and not be able to put dentures in, and I mean, that's their confidence. I mean, that's their ability to chew. It's their diet. It's so important. And to not include this in the adult dental Medicaid that we're unrolling January 1st, my heart's shattered, really. So I don't know what we can do to change that. They're kind of set in their ways on what they want to cover right now, but hopefully in a year or two that will change. The other thing I wanted to mention, and thank you, Dr. Carlson, was just excellent, is in my MSDA advocacy page, and a question was, I did last Saturday morning a piece on translation services. How big is an issue is translation? And certainly in your education of providers, it is important that dentists provide translation services, even for those who use American Sign Language. And through the American Dental Association, the Maryland State Dental and American Dental Association, we have a provider that can provide these services for ADA members at a reduced cost. For example, it's less than $1 a minute to use the translation services versus traditionally it's over $3 a minute. So, you know, what has that been a barrier? Certainly language for those that are immigrants would be my question. And then in the education component, I think we should include services available to make proper translation, because no one can give consent for dental treatment unless they understand what's being proposed. And if they speak a different language, that's a problem.
So can I jump in here? So Charlie, when I was practicing in Prince George's County, it was a requirement that we provide language translation. Many times you would see families come in and they would depend on the children who spoke English to translate what services were going to occur. And certainly, you know, not being able to speak the language yourself, that was not a reliable source. So, you know, I know in health departments, it is a requirement, and I'm sure in federally qualified health centers. And it is something that needs to be made available to private practitioners. I know we have used Language Line, and there are many other resources, but it is something that is very important to making sure that the populations understand what, you know, what's going to occur in education and everything from the moment they walk in the door, even when they call to make their appointment. They, they need that resource.
It's actually a federal mandate under Section 1557 of the Affordable Care Act that we must provide these translation services, and it's at the cost of the provider.
Does anyone else have a question? Oh, Dr. Romaine, I see your hand.
Thanks. I wanted to say that Jean's presentation, especially, it was really poignant when she was talking about the Afghan refugees being reintegrated. And I think there are thousands coming into Maryland. So just as an example of collaboration, I know that Dr. Albert Romanowski, who's the medical director of state emergency preparedness and coordination, reached out to some of us in the dental community. I know like Dr. Hughes was working on that, MSDA was working on that, to come together and offer and explain the services to the Afghan refugees coming in. So I feel like we could get better at that. Honestly, it was a little interesting to see how someone from the Office of Preparedness and Response tried to reach out to the dental community, because what he told me is he was like looking on LinkedIn and doing all this kind of stuff. And I just thought, wow, even for emergency preparedness, I feel like we would really benefit by getting our communication lines of dental and medical and the state really organized. Because I think even from a point of view of, like an example with the Afghan refugees, or who knows what to come, we need to really have good communication lines as the dental community would be called on in certain situations. Thank you.
Thank you, Dr. Romaine. Dr. Booker?
I just wanted to, again, thank you all for allowing me some time to speak and to just comment on what Charlie's comment was, in that he said it takes a village. And I would 100% agree with that. And one of the things that he said was, with that village, we talk about dental hygienists. And I think that for Dr. Reynolds, perhaps if we revisit the importance of teaching every student dentist how to treat every patient, then we include our dental hygienists in this age 1 education about how to endear that 1-year-old. And so that we don't have, some of us that are only seeing this age 1 child. And that is part of, I think, where the disconnect happens. But I hope that, as we move forward with this, we can include everybody in this.
Certainly. Is there anyone else that has a question? Or Dean Reynolds, do you have any comments?
No, I just wanted to thank our presenters. Very, very informative and helpful. I was going to ask if Dr. Kembers and Dr. Verma might share their notes, even if on paper, so that we would have those as well. We have a lot to work with and clearly a lot of opportunity.
Yes.
Be more than happy to share our notes.
Great.
Thank you very, very much.
Okay.
And then I'd like to ask Delegate Bagnall, do you have any questions or comments for the group?
I apologize. I'm at a conference right now, but I am here listening in, and I just want to say thank you again. I actually feel like this was an incredibly informative and meaningful meeting. I apologize for all the noise in the background. And I just want to sort of make sure that when we're looking, especially when we're talking about childcare and that early dental access, that we're looking at carrots, because we do have such a huge deficit in childcare resources right now, and the childcare workforce has really been impacted, by the pandemic. So as we're looking at how to incentivize those, those pre-K visits, that we want to think strategically on how to incentivize it without impeding what is already a limited resource. So that's just sort of my takeaway to put to the group. But thank you so much, everyone, for not just looking at the barriers, but coming in with very concrete ideas of how to address them.
Thank you, and thank you for your continued support and being here. So let's, our next meeting is scheduled for September the 15th, and you will have a final draft. Tyler and Lindsay have been working diligently, and they will have a draft of the final report sent to you, I think, by September the 12th. That will allow us to have discussion on our September the 15th meeting. So we look forward to that. And if we don't have any other questions or comments, I'll say good evening.
Good evening.
All right.
Take care, everyone.
Thank you so much, everyone.
Thank you.